We wrap up Disc 1 of ACCEL with a discussion I had with Dr. Ben Freedman, Professor of Cardiology and Deputy Dean of Medicine at the Concord Clinical School at ANZAC Research Institute in Sydney, Australia, on screening for asymptomatic atrial fibrillation. So Ben, welcome to ACCEL.
Well, thanks, Fred.
Perhaps you can review some of your experience with this interesting problem and some of your thoughts about how we should move forward with screening.
I got interested in this because I report ECGs for people who are coming for a pre-admission clinic. Over the age of 40, if they're coming for a minor procedure and they're ambulatory, they come in and have an ECG if they're over 40. And I saw lots of people with AF, and I wondered how many of these people really didn't know they had AF. So we did a study in about 3,000 ECGs over a few months and found that over the age of 65, we had 1,500 ECGs, and about 7% had AF. And of those, 10% did not know they had AF. So these are new AF. One of the more interesting things that we did was to look at whether the patients were symptomatic, because they all filled out a questionnaire. And only 20% had palpitations or any other symptom that might make them go and see a doctor. And their average heart rate was 78. So these people don't have tachycardia, although they've got AF. They don't know about it. They don't have any symptoms. And their CHADS VAS score was 3.8. That means they have a 4% annual risk of stroke. So here you have a really high-risk population, 4% annual risk of stroke, don't know about it, no symptoms, unlikely to see a doctor. If you really want to look for these people, you probably need to look in the community.
Okay, so what are your thoughts about taking this from the hospital or the doctor's office into the community?
We got interested in this and did a systematic review, which we also presented here. And some of my colleagues have done this review, notably one of the physiotherapists who's interested in this area, who wants to work in the community. And what we found was there were 28 papers that have looked at doing a single screening ECG or pulse check, and 111,000 subjects that they've looked at. And the finding was that over the age of 65, about 4% had AF, but 1.6% had AF that they didn't know about it. So that's really a very high proportion to me, and it was very interesting that the studies that were done in the GP surgeries, general practice, family physician, or in an outpatient medical practice had 1.6%, and an identical percentage in those were just straight out community screening. So that tells me that there's a lot of it about. This is just with a single ECG. And if you do more than one ECG and do it repeatedly, your pickup rate will increase too. You'll pick up the paroxysmals. And these are people really at high risk of stroke, where we not only can define the high risk of stroke very quickly, but we've got very effective drugs that can reduce the risk of stroke.
So the next thing is to develop some screening tools in the community. I mean, obviously, we can't get the whole community to go to a doctor's office and have an electrocardiogram done. And I know there's technology moving forward that would allow rhythm checks, pretty easy tools. I know that in the United States, a physician invented a little attachment to the iPhone that would allow somebody to check their heart rhythm. There are other instruments being made. So what are your thoughts about going out into the community with some of these newer tools to screen asymptomatic patients for AFib?
First of all, I guess we talk about screening asymptomatic patients. These aren't patients yet. These are just subjects. And going out screening and turning a subject into a patient is quite a difficult thing to do. But the technology allows us to do it. We've been looking at, as you say, it's a novel device that attaches, just a case that attaches on the back of an iPhone. And the really nice thing about this is the ubiquitous nature of iPhones. In Australia, about 25% of the population own an iPhone. I imagine it's even more in America. So with this type of device, you can easily screen for it. Not only can you see the ECG displayed on the iPhone, and you can have it sent immediately to the iCloud, and it can be processed, sent back. If it's in a general practitioner's or doctor's surgery, it can go immediately into the record, or it can have a computer algorithm that diagnoses what the rhythm is and comes out and says you've got a normal rhythm or you've got probable AF. I think these devices could revolutionize screening because before this we weren't able to do it. And now I think there are a number of different devices that can do it, but we can actually go out and do it. I think that AF will become the hypertension of this decade because we finally will have tools that will allow us to screen.
Cardiologists aren't used to what I would call the population health dimension of healthcare. We wait for sick patients to come in the office and try to manage them. But we're really talking about this business of population health, not patients, as you mentioned, but people, just considering themselves normal who have something going on. And I just wonder what your feeling is about getting the world of cardiology or even primary care to start thinking in population health, because it's a much different way to do things than we're used to at this point.
Well, I think you have expressed this to me in the past, that if we're going to make an intervention, and I think the Million Hearts campaign of the American Heart Association requires about 100 million people to be screened if you're going to save that many lives or prevent strokes, prevent heart attacks. All these cannot be done in doctors' surgeries. The other problem, of course, is that if people are not symptomatic, they will not go to a doctor's surgery. And the worst thing you want is the very first time that a person declares themselves to have AF is when they present with a devastating stroke or even die. So I think if we're going to make an impact on this disease, we have to diagnose it while people are asymptomatic and treat it before they have their stroke.
So the message here is that, particularly in the world of cardiology, we should be working with communities and screening programs to search for these patients. It'll bring us more patients, obviously, if we find AFib, but the fact is that we can't, as you say, wait for somebody to get a stroke to find out that they have AFib.
We absolutely agree. We've started a study we call Search AF, where we're looking at trying to diagnose atrial fibrillation in pharmacies. And a lot of people visit their pharmacy, people who are well, and if they're over 65, we invite them to have a 30-second ECG. And we already in the first 250 patients, we've detected a lot of atrial fibrillation. Many of these people don't know they have it. Some of them, their doctors know they have it, but the patients don't know they have it. So we've got a lot of educating to do, both in the general public and probably in our own profession.
And I would propose that should be considered in the realm of cardiology and for cardiologists to deal with. Again, let me thank you for being here. This is a very important topic. As you're aware, the more we see our population getting older, the more we're going to find asymptomatic atrial fibrillation. So the screening tools are going to be very important. And I guess we'll look forward to some of the data from the screening programs that you're interested in doing as well. So thanks again.
Thank you, Fred.
That concludes Disc 1 of ACCEL. For details about studies discussed, refer to the written summary that is included as a PDF file on Disc 3. Disc 2 begins with a discussion on randomized comparison of adding cilostazol versus doubling the dose of clopidogrel after PCI.